Thank you. Yeah, I'm honored to introduce our final speaker after this excellent conference. Dr. Daniel Ehlke. He's an associate professor of health policy and management. He's been a member of the Downstate School of Public Health faculty since 2010, having completed his doctoral studies in political science at Brown University. Dr. Ehlke's research interests include health system design and identifying political ingredients for system reform. In addition to studying the American healthcare environment and the impacts of the Affordable Care Act, he closely monitors developments in systems worldwide, most notably the British National Health Service. A particular area of emphasis in his work is the tension between the conception of healthcare as a right versus elements of medical consumerism. At Downstate, he teaches courses on introductory health policy and management, health advocacy, and international health systems. Dr. Ehlke, thank you so much for bringing this conference to an end.
I want to start off today, and thank you for that wonderful introduction. I very much appreciate it. I want to start off today by saying how appreciative I am of being a part of this tremendous gathering. I have learned immensely from the speakers today. I hope maybe you'll learn a thing or two from me, though at this point, I'm not sure what more I might be able to add. So I'm coming to this from a feeling of great modesty in that regard. As indicated, in the introduction, I am a professor of health policy here at the Downstate School of Public Health. I come to public health itself as a bit of an outsider, having come from history and politics, which is one of the many streams that comes together to form public health. But I take very seriously my role to introduce students of all stripes to the basics of the American healthcare environment. You'll notice I say American healthcare environment because I strongly believe that what we have, our healthcare arrangements in this country, are simply too incoherent at the end of the day and fail to come together cohere in such a way as to warrant the word system. We do not have a healthcare system in this country. We might have several nested systems within our overall arrangement, but does what we have add up to a system? I don't think so. And, I'm going to touch on several of the points that I think perhaps illustrate this a bit during my presentation to come. I am extremely, first of all, just really blown away by the wonderful work that all of you are doing in the community. And that has given me tremendous optimism for what might lie ahead. Also giving me optimism is, again, the outstanding policy and advocacy work that we see here in New York. Measures like that opening Medicaid, or at least a portion of Medicaid, to undocumented immigrants over 65, starting just this year, actually, a policy intervention that was a bit of a sleeper, as it were. We've also seen efforts to expand access to basic healthcare beyond emergency care, right? Through the New York Essential Plan and through other means. And there continues to be active advocacy moving in that direction. Elements like that give me optimism. Elements like what we heard in the presentation from Dr. Chang and others give me optimism. However, I'm brought up short a bit at the same time by simply the crushing of reality. 2 points stand out. Today, the first thing I did, I wake up, start getting my kids ready for school, turn on the television. I wanted to see the latest when it came to the landfall of Hurricane Milton. Happen to have the Weather Channel on. A commercial comes on, political advertisement, that comes from an anti-Harris PAC, a shadowy PAC of some sort. It wasn't clear exactly who was behind the ad. But the ad, like so many that we find, trafficked in demonizing migrants, for instance, villainizing them, stating that they are a source of crime, and included the egregious tagline, "If you can't survive the night, how can you survive the next 4 years?" The other point, that I was approached with today is, once I arrived at my office, checked my email, I found that we are once again before the Supreme Court this very moment, or at least the last few hours, relitigating DACA once again. How many times have we been through this process once again? How many times will we be going through this process once again in the future? Again, it's points like that, it's elements like that that leave me feeling a little bit tired, a little bit exhausted, and certainly fearful for the future and for what it holds. But I think through what we've heard today, that I'm coming down more on the side of perhaps cautious, guarded optimism, as it were. But anyway, just a few remarks by way of preface. Let me share my screen. Hopefully you'll be able to see my slides. Can everyone see my slides? Give me a thumbs up, maybe.
Yes.
Great.
You can also see the slide deck on the side if you wanted to.
Yep. I'm going to take care of that now. Great. All right, always a dicey proposition. I always tell my students, it's a dicey proposition to start a slideshow on Zoom, because with all of the screens doing what they are in the background, you never quite know if it's going to be a smooth transition over. But, I think we got there, fortunately. I'm going to talk a little bit today, kind of the patchwork quality of coverage, health coverage, when it comes to immigrants, particularly undocumented immigrants, but really, immigrants of various stripes. And I think some of the same themes that we've touched upon, already today are going to come back to the fore. We very much face a push and a pull within our politics. And that push and pull is against, on the one side, an instinct toward exclusion, toward carving out the common benefits of a democratic society, toward defining an us by way of contrast of a them, all too often along the all too artificial lines of ethnicity, race, place of origin, religion, any number of dividers, so to speak, dividing quotients, right? Measured against that is the idea that America fundamentally presents itself to the world as a nation of immigrants. Give me your huddled masses, ellipsis. Everything else that comes after that, right? Our effort through decades, indeed centuries, to try to live up to our ideals that, many take great pains to state on repeated occasions, but that all too often we're seen to fall short in terms of actually acting on those ideals. One of the recent inflection points that we saw in our healthcare politics certainly surrounded the Affordable Care Act. So some of what I say today is going to kind of take us back to that recent period in our history. And I want to show how, again, our ambivalence toward coverage, extending coverage toward particularly undocumented immigrants, really played out when it came to this larger effort to make healthcare more accessible, more affordable to as many people really as possible, or as politically practical, perhaps, might be a more accurate way to put it. So again, I think we've already visited many of the historical roots of immigration health coverage exclusions. I'll touch on that a little bit. But I also want to look at the current state of coverage that we see not only here in New York, but in jurisdictions around the country. And also look at, some of the leading proposals for reform. When it comes to our healthcare environment overall, again, catch me if I say system, because I'm not supposed to. I really should have like an electric shock every time I say healthcare system within the context of the United States, but alas, I don't. Our healthcare environment, nonetheless, has long been marked by really the huge amounts of money that go not toward care itself, but often toward exclusion of those who are, for whatever reason, deemed ineligible or quote unquote undeserving of care. This really goes back quite a ways. The roots of immigrant exclusion, of course, can be traced all the way back to the early 19th century, if not before, certainly. Public charge laws, the efforts that were undertaken on the part of jurisdictions to try to exclude those who couldn't provide evidence that they would be economically self-sufficient. For instance, these go all the way back, basically to our founding, but certainly began to really take root during the 19th century. This effort to sort out people, sort out different immigrant groups. After all, most of us in this country, aside from indigenous populations, are in fact immigrants of some sort or another, but dividing up immigrants into, again, those deemed us deserving, those deemed some other undeserving. We talked about that othering a bit earlier today, obviously, and how that has gone on and how it's been perpetuated over time. It has also defined ongoing efforts to really, expand healthcare coverage to larger and larger populations. So ever since the early 20th century, when it first became clear that the bulk of the American populace was no longer going to be able to afford healthcare out of their own pockets, it became a political campaign among many to build some form of national health insurance coverage, modeled very often on the social insurance systems of countries like Germany. The German system has been around since the 1880s, so has a long pedigree. And we just didn't get there for a variety of reasons. I think we can kind of skip to the chase in that regard. But we had various sort of moments when it looked possible, starting with the 1910s and efforts by groups such as the American Association for Labor Legislation, a progressive group that, again, was determined to basically import a German social insurance system into the United States. Unfortunately, their timing was terrible. They tried to introduce it around 1916, 1917, right on the eve of World War I. Ouch. We then had another effort that was launched by some of the same progressive figures, slightly older, slightly wiser, perhaps. By the 1930s, they gathered around Franklin Roosevelt, who was their great hope in terms of a president who might lead the way toward more comprehensive coverage, covering more people and offering higher quality coverage. He wasn't interested. He was a political pragmatist, and he feared that adding on national health insurance to Social Security would sink his entire program, effectively. Now, at that point, and this is where the other part of our story comes in, really, at that point, progressives had one more battle during the late 1940s to attempt to enact broad-scale national health insurance coverage. That, too, failed. And at that point, they realized that instead of continuing to bang their heads against the wall, perhaps a more promising strategy would be to target groups that could broadly be seen as deserving. And again, I'm making air quotes. You can't probably see it, but I'm making air quotes at this point. And so again, we see this return to a theme of inclusion, of comprehensive coverage versus exclusion. And that lies at the very root of what would become Medicare and Medicaid. It was a shift, a pivot away from coverage for everyone to coverage for some. And the group that, again, was identified as particularly deserving was those over the age of 65. And that at least gave us Medicare. But again, this narrative should give you a sense of how kind of begrudging benefit structures have often been. And they often, again, get shifted, get pivoted toward this continuing artificial divide between us versus them, the deserving, quote unquote, versus the undeserving. In the process, just as Medicare and Medicaid are getting underway, Medicaid was designed to really cover the other cracks in our healthcare environment, those that excluded many who were less wealthy. And great pains were made to ensure at that point that also excluded from Medicaid, except in emergency situations, would be undocumented immigrants. So again, there's this opening of new benefit structures paralleled with a determined theme of exclusion from the very start, really. Now that brings us, up to the present. President Obama in 2008, 2009 was putting together the framework for the Affordable Care Act. And at that point, he was barnstorming across the country, and this all really moved toward a climax in a joint address to Congress, to both houses of Congress. And, it had all the pomp and the ceremony of a typical State of the Union address. Here, President Obama was attempting to rally the troops and ease opposition to the Affordable Care Act, which notably expanded Medicaid to initially everyone within about 138% of the federal poverty line on the one hand, and created marketplaces or exchanges across the country that would cater to many of those individuals who did not receive coverage through their employer. At the same time, again, great pains were made, just as we are expanding coverage, attempting to bring more people in. Efforts are made to make sure that undocumented immigrants remain excluded. So under the ACA, for instance, undocumented immigrants remain locked out of typical Medicaid programs, again, outside of emergency settings. And they may not receive subsidies on the marketplaces to receive coverage through those individual marketplaces, which were to be again, a key method through which coverage was to be expanded. Now, in September of 2009, again, President Obama addressing a joint session of Congress and makes a point of going out of his way to state that nothing within the Affordable Care Act extends benefits to undocumented immigrants. At which point, Representative Joe Wilson, pictured here from South Carolina, loudly proclaimed, "You lie." Some of you may recall that what was then a shocking moment. Little did we know that it opened the door to a new era when it came to talkbacks between the president and Congress. But really crystallized, again, this moment and this tension between, again, promoting expanding coverage and continuing to maintain exclusions of undocumented immigrants that remain in place, and indeed, in some ways, expanding those exclusions around new benefits, taking the trouble to erect new fences, as it were, around benefits, again, that were ostensibly designed to collectively offer greater coverage, greater access to more of the American population. So current coverage options, again, I don't think I need to go over much of this at great detail. It's been touched on before, and many of you live this in your day-to-day life. Again, I'm just an academic here in a school of public health. I'm not actually treating patients. You know this better than I, but I will say a bit about this nonetheless. The passage of EMTALA in 1986, a very interesting political moment during the very heart of the Reagan era, which of course was known for its greater austerity, anti-government tendencies, really a tightening of benefits, the greater exclusions, really, at the end of the day. Nonetheless, this era also saw the passage of EMTALA, which again requires emergency treatment effectively of anyone passing through the doors of an institution. And this covers any institution significantly that accepts Medicare funding. So that is the way that the federal government was able to apply EMTALA to just about every hospital facility across the country. And this is regardless of insurance status, certainly immigration status, obviously. Again, I say this is an interesting moment partly because of the tension between the very conservative politics of the time. But EMTALA also comes at the exact same time. It's part of, in fact, COBRA, the Consolidated Omnibus Budget Reconciliation Act, that, among other things, also extended health benefits to those who go between jobs, for instance, who lose their job, go to another job, potentially gives them the option to extend benefits. One of the ways that I often tell students, you can tell that we don't have a healthcare system in this country. COBRA, a significant part of our healthcare system. And I ask people, well, what do you think it stands for? And some people try to come up with, continuation of benefits, something or other. No, it stands for Consolidated Omnibus Budget Reconciliation Act. Again, nothing to do with healthcare, presumably, and yet here we are. It was yet another element that was tacked on to a giant catch-all bill, as we so often see happen in this country. 1986 was also the year, interestingly enough, that we saw the last major legislative immigration overhaul as well. So I found it striking that 1986, all of this is happening roughly at the same time. Of course, we know too that while EMTALA patches, an immediate hole and makes sure that care is available again to anyone who needs it in an emergent setting, it can lead to quite a bit of uncompensated care. Of course, for hospitals, there are various fixes for that. Not all of them are complete, and of course, it says nothing about effectively or very little about what comes next in terms of continuity of care, indeed. And for that, what comes next, we need to think about, what the current policy climate looks like. This is a sample document that I include. This is the explainer that is on the New York Department of Health website, New York State Department of Health website right now, explaining what benefits are available to what types of immigrants. And no greater symbol, I think, can be seen as our careful efforts to, again, build walls, build fences around various communities, not only, between immigrants overall and the rest of the country, but between different types of immigrants. Now we carefully classify everyone. You're not designed to be able to necessarily read all of this, but it just gives us a sense of the complexity overall, how anyone can be expected to keep track of this, whether it be immigrants themselves, practitioners, medical providers, I don't know. I certainly find it difficult to follow, and I suspect that many of you do as well. But this is in New York State. This is in a state, after all, that in some ways can be seen as being a bit more, at least, sort of begrudgingly generous when it comes to extending benefits to immigrants. I mentioned the brand new policy opening larger portions of Medicaid to undocumented immigrants over the age of 65, at least those who are income eligible in New York. So it's not necessarily all undocumented immigrants, even within that population. There is always a caveat. And again, the amount of money, the amount of resources that we spend toward, again, building these walls, maintaining these walls, these fences, it never ceases to confound and amaze. So there are, again, possibilities for reform that we see here in New York at the local level. And what I always remind students is that, if you're trying to keep track of where the latest reform efforts, may come from, yes, you can look toward Washington, but Washington isn't always going to deliver, particularly in a setting like we have now where Congress is in recess. Basically, nothing is going to happen until at least after the next presidential and legislative elections. So we need to look to the state level. We also need to look to the courts, of course. I always tell students, keep one eye on the legislatures, keep one eye on the courts when it comes to health policy developments. So I talked about again, this modest expansion in Medicaid to at least cover those over 65 who are income eligible in New York. There's also a coverage for all bill that went fairly far within the state legislature, looking to expand non-emergency coverage to basically all undocumented immigrants within, again, that about 138% of the federal poverty line, which is, the same level, actually, that the overall Medicaid expansion was originally set to. Originally, the law was written in such a way that states were required to expand their Medicaid programs to that point, or else lose the entirety of their federal share of Medicaid funding. The Supreme Court, some of you may recall, came back into session and determined that was coercive. And as a result, the Medicaid expansion itself is voluntary for states. And that's why we have a situation today whereby 40 states have opted to take the federal government up on that expansion. 10 states remain outside of it, including several biggies, particularly for immigrants, Texas and Florida. And no surprise, the uninsured rate in Texas remains at, about a quarter of the population. If we drill down further into some of the southern Texas counties, particularly those near the border, it is estimated that the uninsured rate is closer to about 49%, about half of the population lacking coverage. So while certainly the ACA held significant promise when it came to extending benefits to really, as many different sorts of population previously not covered as possible, that notably did not and does not to this day extend to undocumented immigrants. And even those local and state jurisdictions that may be interested in designing policies that would extend benefits further to undocumented immigrants often run into a real thicket of challenges, particularly if there is even 1 cent of federal money involved because of the blanket exclusionary policies that remain in place. So again, I hope I am ending with on a mixed note, a note of some guarded optimism, but really a sense of how far we have to go, particularly if we are to guarantee not only, benefits that will compensate more hospitals for the emergency care they provide for immigrants, but really funding continuity of care. In public health, we know all too well that the transmission of disease knows no boundaries. It respects no limits when it comes to your race or ethnicity. From an individual well-being and from a public health standpoint, it just makes sense to expand benefits to as many people as possible without all of these caveats attached to it. However, given the historical legacies that we contend with, we continue to face many, many challenges in that regard. Thank you very much for having me today. I really appreciate it.
Thank you. Thank you very, very, very much. Virtual claps, Dr. Ehlke. That was absolutely wonderful and definitely a part of healthcare that we don't often talk about, particularly as emergency physicians, right? We just see the patients in front of us, take care of the patients. It's part of why we all probably, at least one reason why we went into emergency medicine is to not care about people and their coverage, right? Because we have to see everyone. But truly, indeed, it does impact our patients. And I was just texting with Dr. Benson and saying that, fortunate or unfortunate as it may be, we do sometimes get patients coming into the emergency department as a gateway to get to the OR or to get to other services because they are undocumented and don't have insurance. And so, as is for all emergency departments, people are trying to find a back door to be able to get them care. And so I'm just, want to bring to the attention of my colleagues that this truly isn't just something that's theoretical, but that is a part of our daily practice. So any questions? I think that was a great summary of all the topics that we talked about. I guess one of the things that I would say is, and sorry to put you on the spot, but since we all are going to be voting less than a month from now, perhaps you can give us just a one-liner on each party's proposal for healthcare, if you know it, if you are aware.
It's sometimes hard to know. You're exactly right. Absolutely. Thank you for that preface. I appreciate it. So, on the Democratic side, we have really, I don't think you could call it an ambitious healthcare agenda. It is really building on the legacies, again, of the Affordable Care Act, which, as we've seen, has real shortcomings. Unfortunately, nothing being said, really to speak of when it comes to extending coverage to undocumented immigrants, anything along those lines. However, I will say that when it comes to innovative health policy proposals, the Harris campaign did come out with a proposal to fund long-term home nursing care under Medicare. So as many of you will be aware, this is often care that if it's not funded, to a large extent out of pocket and through, running down of assets, often then gets transferred to Medicaid. And so the proposal here is to move that really, that piece into Medicare and to finance it through an expansion of the negotiation of drug prices under Medicare as well. So this really is kind of an innovative policy direction and one thing that I would point to when it comes to the Democratic camp. On the Republican side, it's been interesting because we had thought that efforts to eradicate the Affordable Care Act were behind us. And yet in recent weeks, J.D. Vance and to some extent Donald Trump himself have come out with statements suggesting that they're ready to once again take on the ACA, attempt to, if not repeal it, then perhaps try to roll away large portions of it. In the name of really, benefiting those who are, maybe middle class, upper middle class, trying to reverse some of the policies under the ACA, which raise prices for insurance premiums, because you may recall that under the ACA, insurers could no longer discriminate on the basis of pre-existing conditions. Well, for some people, that means that their premiums have gone up over time. And so the idea is to move to a pre-ACA condition where those who are younger and healthier generally are in one risk pool. Those who are older and relatively sicker would be moved to so-called high-risk pools. Now, the problem with this, it's good for some whose premiums might go down, but for those who are older and sicker, and all of us are going to be older and sicker at some point, is that these high-risk pools don't work well. They almost invariably collapse unless they are provided with a huge amount of seed money from governments. And often that seed money does not hold out, and they often spiral into insolvency. So I don't think that's a practical solution to this issue, but that really is a large part of kind of what they're proposing. I would also say a sleeper issue is Medicaid. So under the Democratic administration, there really aren't major proposals for reforming Medicaid per se. It will largely remain as is. But under the Republican side, there are suggestions that they could try to move Medicaid to a system of block grants. Today, Medicaid is an entitlement. The money follows those who are eligible. So if more people are eligible, the money naturally flows. If it is block granted, that means a state would get a lump sum of money, and if they run through that money, too bad. And if you want a sense of how badly this can work, you need only look to Puerto Rico, which has a block granted Medicaid system, and it works very poorly. And so the proposal is to extend this to the entire United States. And so that's one thing to watch. It's part of Project 2025. It's unclear how much they're going to embrace, of course, of that, but it's something to watch nonetheless.
And Humberto, I just saw a kind of advertisement by Pharma challenging the new executive order, I think that President Biden did about able to negotiate with the drugs company for the medication. And I raise this because I just mentioned the commercial determinant of health, and that the World Health Organization and most sectors identifying that the private sector have much more power than government in this moment, defining health and health outcome at all levels of politics and intervention. So it's interesting, Biden passed this initiative, and already the pharmaceutical company has major ads out with elder people saying that this is not good for them because the price is going to go up, because if the companies can't make money, they're not going to make certain drugs available. Yeah. Right. So either I can rip you off or I wouldn't have the drugs available. But I'm just surprised that they're able to do advertisement with elderly saying that this is bad for elderly people. If you were in Europe, you can't do that, right? You can't.
Absolutely.
You can advertise against the government providing universal health care. So I don't know what people, but this is significant. At this moment, pharmaceutical company opposing the capacity to reduce the cost of drugs for most community. And I think that's significant, that we have to look at the private sector and not just look at government, but the role of these transnationals and corporations that are defining the totality of what's happening in health and other areas of the economy.
Absolutely. I'm glad you brought that up. Yeah, so the drug negotiation policy is a bit precarious, I will say, as those advertisements indicate, and they're also putting their money where their mouth is. They have also tied this program up in court as well. So while all this is going on, we're seeing the ads, but in less prominent circles, this is also moving through the courts. Now, so far, the courts have been skeptical of the arguments, but that's not to say that you may not get a federal court somewhere that puts some sort of injunction on it. That could happen any day.